He had been coughing for 2 years. Not the cough that arrives with a cold and fades within 10 days. The cough that settled in reliably every early evening, took up residence somewhere at the back of the throat, and refused to leave regardless of what he tried. Cough drops. 2 rounds of antihistamines for suspected allergies. A visit to a pulmonologist who ordered a chest x-ray that came back completely clean. A follow-up with an ENT who examined his throat and found nothing structural that explained it. In 2 years, through 4 specialists and multiple investigations, not a single physician had asked him one question about his stomach. Raymond was 68. He came to my office because his daughter had suggested, almost as a joke, that it might be related to reflux. He did not believe it was reflux. He had no burning behind his breastbone, no sour taste climbing up his throat after meals. What he had was a dry, persistent cough that was reliably worse in the evenings, disruptive enough at night to wake him once or twice a week, and a voice that by dinner time sounded like he had spent the entire day speaking loudly in a crowded room. If any of this sounds familiar, a throat that feels raw without a clear explanation, a voice that tires well before the end of the day, a cough that flares after dinner or pulls you out of sleep at 2 in the morning, I want you to stay with me through this entire conversation. What I am going to walk you through connects to something most people, and even many physicians outside of gastroenterology, rarely think to investigate. There is a version of this condition most people recognize immediately, the burning behind the breastbone, the sour taste after a heavy meal. We will come back to that because there is considerably more to it than most people understand. But the throat, the tired voice, the cough that simply will not resolve, that is the part almost nobody connects to the stomach. And when I traced Raymond's 2-year cough back to acid reflux, even I sat with that for a long moment before I said it out loud. My name is Dr. Andrade. I work with adults, most of them in their 60s and 70s, who arrive carrying symptoms that have been thoroughly investigated without ever reaching a clear answer. Reflux is one of the conditions I see underestimated more consistently than almost anything else in practice. Not because it is rare, but because it hides in places people do not think to look. Before we go any further, I want to ask you something. Drop a comment right now and tell me your name and where you are watching from. I genuinely read every comment, and I love knowing who is part of this community around the world. Take 5 seconds and do that right now. Now let's start with what you may already recognize. The burning behind the breastbone, the sour taste that rises after a heavy meal, the bloated, weighted feeling that sits in the stomach for an hour after dinner, the belching that follows a large plate of food. Most people file these under just part of getting older, or something I ate. And occasionally that is exactly what they are. But when they happen consistently, more than twice a week, or regularly enough that you have started planning meals around them, they are no longer background noise. They are a message. That message is this: stomach acid, which is designed to stay within a specific zone of the digestive tract, is moving into a space that was never built to tolerate it. Your esophagus has a lining suited to food passing through quickly. It is not suited to repeated acid contact. When that contact happens often enough, the tissue responds the way all tissue responds to repeated irritation. It inflames. Clinically, we call this esophagitis. Left unaddressed long enough, esophagitis affects sleep quality, nighttime breathing comfort, the strength and steadiness of the voice, how comfortable eating has become, and, because chronic low-grade irritation and disrupted sleep are quietly exhausting, how much energy is left for the entire day that follows a poor night. I have had patients who went through cardiac investigations, pulmonary investigations, thyroid panels, scan after scan, when the actual source of their discomfort had been sitting one organ over the entire time. To understand why any of this happens, you need to understand one small structure that most people have never heard of. Once you understand it, almost everything else in this video will fall into place without effort. At the base of your esophagus, at the exact point where it meets your stomach, there is a ring of muscle called the lower esophageal sphincter. Think of it as a one-way door. When you swallow, it opens briefly to allow food into the stomach, then closes again firmly to keep everything below it exactly where it belongs. When it works correctly, you never notice it. That is the whole point of a healthy digestive system. It runs silently. Reflux begins the moment that door starts opening when it should not, or fails to close all the way. Several things weaken it. Carrying extra weight increases abdominal pressure from below, pushing against the door from the outside. Fatty meals relax the muscle directly. Large meals stretch the stomach and force the door to stay open longer than it is designed to. Alcohol and caffeine both chemically relax that same muscle. And for some people, there is a structural factor called a hiatal hernia, where part of the stomach sits slightly higher than it should, above the diaphragm, that makes the door mechanically harder to keep shut. A patient described this to me once as a screen door with a weak spring. It does not fail dramatically. It simply does not quite latch. And every time it swings open, even slightly, whatever is on the other side drifts through. There is also a reason this becomes more common after 60 than it was at 40. Muscle tone throughout the body changes gradually with age, including in this valve. Connective tissue around the diaphragm loosens over the decades, making a hiatal hernia more likely to develop than it was 20 years earlier. This is not a failure. It is mechanical wear on a structure that has been working without a single day off for 60 or 70 years. But here is what surprised me most when I began paying close attention to this. When that door fails badly enough, acid does not always stop at the esophagus. Sometimes it travels much further than most people, and most physicians outside the specialty ever think to consider. When reflux happens at night, lying flat removes the gravitational assistance that keeps that weakened door closed during waking hours. Acid can travel high enough to reach the back of the throat, and in some people, the airway itself. Doctors call these extraesophageal symptoms occurring outside the esophagus, and they include a chronic dry cough that reliably worsens in the late afternoon or overnight, a persistent need to clear the throat, a hoarse or fatigue-sounding voice noticeably worse by evening, recurring laryngitis that does not respond to standard treatments, and a sensation many patients describe as a lump permanently settled in the throat that never fully resolves. Some people experience brief choking episodes during sleep, waking suddenly with a gasp and no understanding of why. Some notice their asthma worsening with no identifiable trigger, their inhaler becoming progressively less effective. There is a documented relationship between acid reflux and sleep apnea, not a simple one-to-one causation in every case, but a connection significant enough that I now routinely ask every patient with unexplained nighttime breathing problems about their digestion before I discuss their airway. Here is the mechanism behind this. Acid sitting at the back of the throat triggers a small protective muscle spasm in the airway, the body's attempt to prevent acid from traveling any further downward. In the moment, that reflex is protective. But night after night, that same spasm response is exhausting for a body that is supposed to be resting and rebuilding. Raymond's cough was never a lung problem. It was acid reaching his throat almost every night while he slept, irritating tissue that had no biological defense against that kind of repeated exposure, while 4 specialists examined his lungs and vocal cords and found nothing wrong. One mechanism, one door that does not fully latch, 2 locations, the burning chest and the persistent throat, that most people spend years treating as 2 entirely separate problems. Let's talk about what actually helps, starting with the hours you spend lying down, because that is when this door is working against gravity instead of with it. The first change I recommend, and the one I believe matters most for nighttime symptoms, is raising the head of the bed. Not with extra pillows. Pillows bend the neck and upper back into a posture that creates its own problems over time. What I recommend is raising the actual head of the bed frame by approximately 10 to 15 centimeters, using sturdy risers placed under the bed's feet. This keeps the entire upper body on a gentle, consistent incline through the night, so gravity is quietly helping that door stay closed for 8 hours instead of working against it. Second, give your stomach time to empty before you lie down. I advise my patients to avoid solid food for approximately 3 hours before bed, and to stop drinking liquids about 2 hours before sleep. A stomach that is still actively processing food when you move to horizontal position is a stomach with elevated internal pressure pushing against that door at precisely the time your body's defenses are most limited. Third, and this surprises many people, smaller, more frequent meals consistently outperform fewer larger ones. A large meal stretches the stomach significantly, and a stretched stomach increases the pressure on that door and holds it under strain at its fullest point. Smaller portions distributed across the day simply demand less of a valve that is already working below capacity. I also recommend sitting upright, not slouched, for at least 20 minutes after eating, and avoiding the habit, common among adults whose afternoons have slowed, of lying down shortly after lunch. That window, stomach full, body horizontal, is one of the most reliable symptom triggers I encounter in practice. And then there is smoking and alcohol. I will not make this a lecture, but clinically, quitting smoking and meaningfully reducing alcohol produce some of the most noticeable symptom improvements I observe, often within just a few weeks of the change. If you have found this channel for the first time today, I want you to subscribe before we go further. This channel is built for adults who want real, evidence-based answers to what is happening in their bodies, not reassurances that attribute everything to aging and send you home without an explanation. New videos every week. Hit subscribe, hit the bell, and come back. This is the part of the conversation I feel most strongly about, and the part I believe is least clearly communicated in the average clinical appointment. There is a category of medications that many adults over 60 take daily without a second thought that may be quietly worsening this condition. Before I name them, I want to be completely clear. I am not telling anyone to stop their medication. These drugs are frequently prescribed for serious, important reasons, and stopping them without medical guidance can produce problems far more dangerous than reflux. What I am telling you is that if you are dealing with persistent symptoms, you deserve to know which medications may be contributing, so that conversation can happen with your physician rather than never happening at all. Anti-inflammatory pain relievers, ibuprofen, diclofenac, naproxen, and aspirin can irritate the stomach lining directly and worsen reflux, particularly when used daily rather than occasionally. If joint pain or a chronic condition has made one of these a fixed part of your routine, that pattern is worth raising. Certain blood pressure medications, amlodipine, nifedipine, and verapamil among them, relax smooth muscle throughout the body, which includes the lower esophageal sphincter. Some sedatives, particularly benzodiazepines, have a similar relaxing effect on that same valve. And a class of older antidepressants, imipramine, amitriptyline, and clomipramine, slow gastrointestinal motility in a way that gives acid a longer window to move upward. What I would suggest is bringing a straightforward list to your next appointment, what you take and when your symptoms tend to flare, because that pattern tells your physician more than a general description of heartburn ever could. There may be an alternative. There may not be, but the conversation should happen with that information clearly on the table, rather than with the reflux and the medication treated as two unrelated facts about your life. Now let's talk about what is working against this door from your kitchen table, because the specific list is more precise than most people expect. The foods and drinks that most consistently relax the lower esophageal sphincter or increase stomach acid directly include peppermint, chili peppers, bell peppers, concentrated tomato products and tomato sauce, chocolate, carbonated drinks, dark coffee, black tea, cured and processed meats, smoked sausages, and energy drinks. There is one habit that deserves its own mention because I encounter it frequently enough in clinic. Drinking strong coffee or mate on a completely empty stomach, particularly as the very first thing in the morning. For many people, this is a deeply established daily ritual, which makes it difficult to examine honestly. But on an empty stomach, with no food to buffer the acidity and no digestive process already underway to receive it, this tends to be one of the most reliable symptom triggers I observe across patients. There is also a mechanical factor, entirely unrelated to what you eat. Tight clothing around the abdomen, snug belts, firmly cinched waistbands, compression garments worn into the evening increases external pressure on the stomach from the outside, pushing against that door from yet another direction. I have had patients whose symptoms improved meaningfully from nothing more than switching to looser-fitting waistbands at dinner. The practical approach here is not to eliminate every item on that list permanently. It is to notice which 2 or 3 appear most consistently in the days or evenings when your symptoms are worst. Most people, once they begin paying attention to the pattern, discover that a small number of specific items account for the majority of their episodes. Removing those few things consistently does more than imperfectly attempting to avoid the entire list. At this point, you understand the mechanism, the nighttime adjustments, the medications worth discussing, and the food patterns worth tracking. For some people, these changes bring symptoms under meaningful control. For others, they help but do not fully resolve things. And that is where medical treatment becomes part of the picture, in a way worth understanding clearly. There are broadly 3 levels. The first is antacids, medications that neutralize acid already present in the stomach. They work quickly, making them useful for occasional isolated episodes. They do not address the valve. They calm the room after the smoke has already entered. The second level is H2 blockers, famotidine, cimetidine, nizatidine, which reduce acid production moderately and sustain that reduction for several hours. These tend to suit patients with mild or intermittent symptoms who need more than a quick antacid, but do not require the strongest available option. The third level is proton pump inhibitors, omeprazole, pantoprazole, esomeprazole, lansoprazole, rabeprazole among them, which significantly reduce acid production and give an already inflamed esophageal lining the environment it needs to actually heal. There is also a newer agent called vonoprazan, which works through a different mechanism and has a notably longer duration of action than most traditional PPIs. The right choice depends on frequency, severity, whether there is visible esophageal damage, and your broader health picture. That determination belongs with your physician, not on the pharmacy shelf. Hold this as your decision threshold. Occasional symptoms a few times a month that respond to lifestyle changes are a very different situation from symptoms most nights that disrupt your sleep or come with a persistent cough, hoarse voice, or difficulty swallowing. And on that final point, difficulty swallowing, food feeling like it is getting stuck, unintentional weight loss, or any sign of bleeding. If any of those are present, do not try the tea first. Call your doctor this week. There are 3 things, almost certainly already in your kitchen, that I recommend as consistent daily support alongside any other changes, never as a replacement for medical treatment when it is genuinely needed. The first is water at room temperature, first thing in the morning, on an empty stomach. Approximately 600 milliliters, roughly 2.5 to 3 cups, taken immediately on waking, with at least 30 minutes before breakfast. Overnight, acid accumulates in the stomach in concentrated form. That volume of water dilutes it and moves it forward into the digestive tract, rather than leaving it sitting at full concentration when the first food of the day arrives. The second is basil tea. Basil contains compounds with mild antispasmodic and anti-inflammatory properties that help calm an irritated digestive lining and reduce the gas and bloating that increase internal pressure on that valve. Prepare it with 4 or 5 fresh leaves or a level teaspoon of dried basil, steeped for 5 to 10 minutes. I recommend this twice daily, after lunch and after dinner, since those are the meals most likely to stretch the stomach and test the door. The third is fennel tea. Fennel seeds contain anethole and fenchone, 2 compounds that reduce gas, ease digestive spasms, and bring down abdominal distension. Since a distended stomach raises internal pressure, and pressure is the primary force pushing that door open, anything that genuinely and consistently reduces gas and bloating is indirectly supporting the same mechanism we have discussed throughout this entire conversation. This can be taken after each main meal, up to 3 times daily. Raymond raised the head of his bed, adjusted his evening eating pattern, and added the basil tea routine after dinner. His cough, the one that had survived 2 years and 4 specialists, was gone within 3 weeks. Not from one dramatic intervention, but because the door was finally given a consistent environment in which to do its job. Reflux is not just heartburn. It is a signal that touches your chest, your throat, your sleep, your breathing, and quietly your energy for every day that follows a poor night. A dry cough, a voice that tires by evening, a restless night with no clear explanation. These are not random inconveniences. They are specific messages, and they deserve specific answers. If what you are experiencing is occasional and responds to what we covered today, that is a manageable pattern you can begin addressing tonight. If it is frequent, if it disrupts your sleep consistently, or if it comes with difficulty swallowing or any sign of bleeding, bring that information directly to your physician. One last thing, if you watch this entire video all the way to the end, I want to know. Comment below right now and say, "I watched till the end." That tells me this conversation was worth your time, and it helps me know what to keep making for you. See you in the next one.